This eHIV review program is presented by DKB Med Radio.
Unfortunately, this patient's case exemplifies the care engagement patterns experienced by people living with HIV with criminal legal involvement during the COVID-19 pandemic. The patient's individual HIV care considerations primarily should focus on ART adherence, virologic suppression, and potential risk for ongoing viremia.
PLWH, Overcoming Post-Incarceration Care Disengagement. Welcome to eHIV Review. PLWH, people living with HIV. Some are arrested and incarcerated, and when they're released back into the community, many risk rearrest by returning to the behaviors that made them criminals. Fewer re-enter appropriate HIV care. What should clinicians do to help bring these patients back into care? What are some of the core drivers of patient disengagement from treatment? What approaches can clinicians use to reinstitute ART adherence in more of these formerly incarcerated patients? What does the evidence say? To answer these questions, we're joined today by Dr. Asa Clemenzi-Allen, Assistant Professor of Medicine at the University of California, San Francisco School of Medicine, and the Director of HIV and Integrated Services at the San Francisco Department of Health. For our guest disclosures and additional CME information, please go to our website, ehivreview.org, and select the Volume 9, Issue 8 link. I'm Bob Busker, Executive Producer of DKB Med's e-Literature Review video programs. Dr. Clemenzi-Allen, thank you for joining us today.
Bob, great to be here, and thank you so much for the opportunity to speak on this topic today.
Our overall learning objective for today's program is to describe interventions that improve outcomes for formerly incarcerated people living with HIV. Our focus for this part of our discussion is to identify services to support care engagement for people living with HIV following release from carceral setting. So start us out in the clinic, if you would please, Dr. Clemenzi-Allen, with a patient scenario.
Great, thanks, Bob. So I'll be talking about a 24-year-old African-American trans woman who I saw in clinic and jail, who was living with HIV, who also had chronic amphetamine-induced psychosis and homelessness, and was taken into the jail for the third time in the last year. The chart review prior to her visit showed that before the COVID-19 pandemic, the patient was consistently engaged in care and virologically suppressed on bictegravir, tenofovir, alafenamide, and emtricitabine, and then 2 years ago became increasingly disengaged from care in the setting of increasing amphetamine use. Clinic visits during that time showed increasing paranoid delusions and aggressive behavior that led to a 3-month clinic suspension. Her HIV viral load measurement prior to this incident was consistently above 200 copies per milliliter, and the provider changed her ART regimen to darunavir, cobicistat, tenofovir alafenamide, and emtricitabine, given the high genetic barrier to resistance. On multiple attempts during that time, the clinic team attempted to enroll the patient in residential treatment programs, but these programs had limited space due to the COVID-19 restrictions. Now, during the year prior to her current visit, she had 2 brief incarcerations and emergency room visits, but she remained lost to follow-up from HIV care. And she failed to follow up with court and was then rearrested and booked into the county jail. Her surveillance labs were collected only during her brief jail stays, and her viral load measurement ranged between 30 to 50,000 copies per milliliter, and the CD4 count decreased to 250 cells per milliliter, and she was treated once for rectal gonorrhea. She was consistently restarted on her home ART regimen, and then discharged with the 2-week supplies from jail, but she had no primary care follow-up. On her third incarceration 1 month later, she again reported that she'd been off her HIV medications following her last incarceration. On intake medical evaluation, she denied any acute complaints, including shortness of breath, cough, hemoptysis, visual disturbances, meningismus, or photophobia. Her exam was notable for normal vital signs and paranoid delusions, but was otherwise unremarkable. Her intake labs showed an HIV viral load that was persistently elevated at 50,000 copies, with a CD4 count of 296 cells per milliliter. She was again started on her home ART regimen and olanzapine, an atypical antipsychotic, to treat her auditory hallucinations. Owing to her failure to follow up with the court on multiple occasions, she was not released prior to her subsequent court dates.
So before the COVID-19 pandemic, she was engaged in care and she was virologically suppressed. And then post-release, the combination of increasing amphetamine use and pandemic restrictions prevented her from entering what would likely have been a beneficial residential treatment program. And from there, it seems she just spiraled downwards. Talk to us in general, please, Doctor, about the challenges this population confronted during the pandemic and its impact on their HIV care cascade outcomes. And with respect to this patient specifically, what could we predict about her HIV disease progression and complications? Doctor?
Thank you, Bob. That's a great question. Patients living with HIV during this period saw a dramatic drop-off in HIV care engagement, an increase in virologic non-suppression as a result of shelter-in-place ordinances. Unfortunately, this patient's case exemplifies the care engagement patterns experienced by people living with HIV with criminal legal involvement during the COVID-19 pandemic. The patient's individual HIV care considerations primarily should focus on ART adherence, virologic suppression, and potential risk for ongoing viremia. First, we don't anticipate a significant amount of adherence to ART during the last year given her persistent viremia. This could portend further CD4 decline, although the kinetics of CD4 decline vary significantly between individuals. Moreover, we would not anticipate treatment-emergent resistance mutations given minimal ART exposure during the prior year. Initial consideration of ART restart should weigh the benefits of rapid ART restart in terms of virologic suppression and HIV transmission, and risk of a complication from immune reconstitution inflammatory syndrome, although the risk in this patient should be minimal given the short interval period of ART non-adherence. Moreover, she had a negative review of systems and a normal physical exam on her intake. In her case, we thought it was highly beneficial to immediately restart her ART and hold off on empiric initiation of any prophylactic therapy until we confirmed the CD4 count.
Strategies to improve HIV care engagement. What might have been done after her release from her earlier incarcerations?
That's a great question, Bob. While numerous interventions have been evaluated to improve care engagement for people with HIV following release from carceral settings, peer navigation interventions have had the most robust evidence. Peer navigation models utilize community health workers with similar lived experience to provide mobile outreach and patient support for clinical care attendants. 2 studies have documented improved care engagement and virologic suppression using peer navigation for patients living with HIV leaving jail. Additional interventions, such as providing substance use treatment following release from jail and providing conditional cash transfers for care engagement, have also shown promise in improving post-release care outcomes for people leaving jail. However, these interventions have been limited to single-center studies and have not been replicated. While pre-release case management is considered the standard of care, the impacts on post-release care engagement are mixed.
The role for long-acting injectable antivirals in this patient population, whether as therapy or for HIV prevention. What does the evidence say about that?
Yeah, this is an interesting topic for our patients that are at risk for virologic non-suppression after leaving jail. Long-acting injectable ART holds a huge promise for improving post-release virologic outcomes, particularly in the wake of the International AIDS Society guidelines endorsing their use among people with HIV with adherence challenges, so long as appropriate case management services can support retention and care. However, significant implementation challenges remain. Of greatest concern is the risk for loss to follow-up from HIV care following release from jail, particularly for patients with a history of minimal HIV care engagement. Future strategies should aim to optimize clinical care engagement, such as including peer navigation, engagement in substance use treatment, and conditional cash transfers prior to widespread use of long-acting injectable ART for people living with HIV with criminal legal involvement. As such, long-acting injectable ART should be reserved for people in this population who have sufficient clinical care engagement to adhere to once monthly or every other month clinic-based injections, or in people who have already been successfully maintained on LAI ART prior to criminal legal involvement.
Thank you, Doctor, for bringing us this case. Our focus for this part of our discussion is to identify services to support care engagement for people living with HIV following release from carceral setting. What are the most important things our learners need to understand and put into practice?
Great. I think it's important for the learners to first understand that the COVID-19 pandemic had a significant impact on care cascade outcomes in people with HIV with criminal legal involvement, a population that was already experiencing significant health disparities. Second is that individual level interventions, including peer navigation, conditional cash transfers, and treatment of substance use disorder, could be used to improve care engagement for this population. And third is that successful implementation of long-acting injectable ART in people with HIV with criminal legal involvement will need to be optimized in order to minimize the risk of treatment-emergent resistance mutations following late or missed injections.
Nice summation. Thank you, Doctor. And we'll return with Dr. Asa Clemenzi-Allen from UCSF in just a moment. Providing the best care for your patients takes more than identifying the most relevant information. It takes expert opinion and analysis of the data, combined with expert advice about how to most effectively put that information into practice. It takes the Johns Hopkins University School of Medicine e-literature reviews. Top experts in their specialties, selecting the most important peer-reviewed literature, analyzing the information, and explaining what it can mean to clinical practice. E-literature reviews, independent medical education, CME, certified by Johns Hopkins University School of Medicine, and presented without charge by DKB Med. Welcome back to today's eHIV review program, focused on interventions that improve outcomes for people with criminal justice involvement, living with or at risk for HIV. We've been speaking with Dr. Asa Clemenzi-Allen from the Division of HIV, ID, and Global Medicine at the University of California, San Francisco, about identifying services to support care engagement for people living with HIV following release from carceral settings. Let's turn now to the focus of this part of today's discussion. Describe post-release approaches to re-engaging PLWH, people living with HIV, in HIV care. So if you would please, Dr. Clemenzi-Allen, take us back to the clinic with another patient scenario.
Great. This is a case of a 26-year-old African-American man who has sex with men who was initially from Indiana during his diagnosis of HIV at the age of 19, who presented to my clinic following a recent incarceration while he was off antiretroviral therapy. In terms of his recent HIV care history, the patient had been admitted to the hospital 1 year prior with pneumocystis pneumonia, during which his CD4 count was less than 12 cells per milliliter, and his serum HIV viral load was greater than 1 million copies per milliliter. He was not engaged in HIV care following hospitalization, and then was incarcerated a year later. He denied any ART use in the last year and declined ART administration while in jail. But fortunately, he did not report any acute medical complaints. His vital signs at the time of the clinic visit were within normal limits. An exam was remarkable only for a low BMI. His labs that were sent from jail showed a viral load of over 900,000 copies per milliliter and a CD4 count that was persistently under 12 cells per milliliter. His cryptococcal serum antigen was non-reactive, and his blood cultures for Mycobacterium avium were negative throughout his incarceration. He agrees to start antiretroviral therapy at the clinic following his release from jail.
One thing I find notable about this patient, doctor, is that despite his HIV viral load, his low CD4 cell count, and even a bout with pneumocystis, he does not seem able to prioritize his HIV care. In patients like this one, what are some of the major drivers of care disengagement?
That's a great question. It's important to think broadly of reasons for care disengagement amongst this population, particularly for patients with syndemic risk for negative care outcomes, such as racial, ethnic, or gender minorities, people with housing instability, or low socioeconomic status, as demonstrated in multiple national studies. While the above reasons may be clearly identifiable during evaluation, some predictors of care disengagement require high clinical suspicion and thorough investigation, such as psychiatric disease, substance use, or stigma.
This patient has pretty much a 7-year history of avoiding ART. During your initial visit, how would you approach improving his adherence?
So the primary goal for in cases like this would be to build rapport and learn about the unique patient challenges as we discussed and identify motivations for engaging in HIV care. Evidence suggests that patients who report that they have providers who understand them as a person are more likely to engage in care and adhere to ART. Interview techniques such as motivational interviewing may be able to support a clinician towards these ends. A thorough interview and relationship building could prompt referrals to appropriate services that could address unmet subsistence needs, medical, and behavioral health needs.
Some good thoughts, Doctor. One last question on this patient. Long-acting injectable antiviral therapy. In the prior case, we discussed that initiating long-acting ART for people who had been incarcerated has significant challenges. One of the key concerns you presented is the need to minimize the risk of treatment-emergent resistant mutations that might occur during missed injections. My question is, how would you approach initiating this ART formulation for this particular patient, a 26-year-old man with a history of incarceration who's now returning to the community and has evidenced a long-standing problem with ART adherence?
Yeah, this is a really interesting situation. First and foremost, I would want to establish consistent care engagement with this patient in community-based HIV care. The risk of virologic failure and subsequent development of resistance mutations should be considered and discussed with the patient when considering this antiretroviral therapy strategy. Moreover, behavioral interventions discussed previously, such as peer navigation and the use of conditional cash transfers, to achieve these ends should be considered in order to improve care engagement. While protocols for initiation of long-acting injectable ART are not standardized within vulnerable populations with adherence challenges, I typically wait until the third or fourth visit to ensure that the patient is engaging consistently in clinical care and to understand whether or not oral antiretroviral therapy may or may not work for them before committing to a long-acting injectable medication. Initiation protocols can be found in a study recently released in the Annals of Internal Medicine by Monica Gandhi and colleagues at the University of California, San Francisco.
Thank you, Dr. Clemenzi-Allen. Our key learning focus for this part of our discussion is to describe post-release approaches to re-engaging PLWH in HIV care. What are the key ideas you'd want our learners to bring back to their practices?
To summarize, patient risk for care disengagement and virologic non-suppression, such as unmet basic needs, concomitant substance use or psychiatric disease, and belonging to racial, ethnic, or gender minorities, should be considered in patients who have been disengaged from care or off antiretroviral therapy. Second is that building trust and rapport in an effort to understand the patient as an individual may work to improve care engagement and ART adherence. And third, long-acting injectable ART should only be initiated after risks for care disengagement have been considered and addressed so as to avoid virologic failure and the development of treatment-emergent resistance mutations.
From the University of California, San Francisco School of Medicine and the San Francisco Department of Health, Dr. Asa Clemenzi-Allen, thank you for sharing your knowledge and expertise in today's eHIV review program.
Thank you so much, Bob, for having me, and it was a pleasure to talk to you and share this information with the learners today.
For eHIV Review, I'm Bob Busker.